Good morning, everyone. My name is Nirav Shah, and I am the director of the State of Maine Center for Disease Control and Prevention. And we begin today's briefing on a sad note. Over the weekend, the Maine Center for Disease Control and Prevention reported the second and third deaths of individuals who had tested positive for COVID-19. The individuals were a woman in her 80s from Cumberland County and a man in his 60s, also from Cumberland County. Both individuals were hospitalized at the time of their death. The passing of these two individuals is a reminder for all of us that every case of COVID-19 is a person, and that every person who passes was somebody's friend, spouse, father, mother, daughter, child, friend, and neighbor. On behalf of the Maine CDC, we send our condolences to the families of those individuals who have passed during this time of grief. I'd like next to provide an update on the number of cases statewide, as well as some other information about those cases. As of right now, the Maine CDC is reporting 275 cases of COVID-19 across the state of Maine. That reflects an increase of 22 cases since yesterday. Of those 275 cases, 49 have been hospitalized at some point during their illness. In addition, 41 of those 275 have recovered and have been released from isolation. Sadly, these numbers also include 3 individuals who passed, the 2 that I mentioned just now, as well as 1 a few days ago. Of these cases, approximately 43 are healthcare workers, and our investigation into their exposures at their different facilities is ongoing. Also, in the past 48 hours, there has been a new county identified with its first positive, which is Somerset County. In addition, there are now 12 cases in Penobscot County. And our investigation is underway to determine whether those 12 cases may represent community transmission. At this time, we have not yet identified that. But again, our investigation is underway, and when we learn more information, we will update everybody. Of all the cases thus far recorded in Maine, the average age of those individuals is 55 years of age. I'd also today like to take a bit of focus on individual cases of COVID-19 that have occurred in congregate settings. We've discussed one such setting, a community in Falmouth, where there have been 6 cases overall. Maine CDC is now aware of additional cases of COVID-19 in other congregate settings across the state. We are aware of 3 cases at a group home in Freeport, and then 3 single cases, one at another group home in Leeds, and then one case at a long-term care facility, and then another case at a separate long-term care facility. What I'd like to do is spend a moment discussing why we are especially concerned about congregate settings, and then talk through what that means for the people of Maine, as well as for our team at Maine CDC. In the past few days, there have been 2 large papers that were published in the literature discussing the particular risk of COVID-19 for individuals in these congregate settings. And by congregate setting, I'm referring to anything from a nursing home to a shelter to any type of situation where high numbers of people may live together, particularly in close quarters. Recent data suggests that when COVID-19 is introduced into those settings, it can spread very quickly. As, for example, was documented in a long-term care facility just outside of the city of Seattle, where a very high percentage of the individuals in that setting quickly became infected with COVID-19. For that reason, when Maine CDC learns of a case of COVID-19 in a resident or a member of one of these congregate communities, we do a few things immediately. The first thing we do is to notify the facility. We notify the facility of what we know and notify them that an investigation by one of our field epidemiologists will be proceeding very quickly. The second thing we do is to ask the facility, the setting, to notify all of their respective stakeholders. This includes the members of that community. It also includes all of the staff who work at that community. In many instances, we also ask the management of these facilities to notify family members of the residents of these communities, so that family members, whether they are near or far, can be made aware of what's going on at the place where their loved one lives. We also ask the management of these communities to consider things like restricting or disallowing visitation outright. We also ask them to make sure that they have a system in place to check for symptoms amongst the rest of the community members. And finally, we ask them to make sure that all surfaces are disinfected and that things like hand sanitizer and hand washing are freely available. We document all of these requests. We even give them templates of the letters of the communications that we've talked about that they can use when they're communicating with their stakeholders. We give them a checklist to make sure on a daily basis they're keeping up to date with what we are requesting them to do. More recently, we have started working with the Division of Licensing and Certification, an agency within the Maine Department of Health and Human Services. This agency, DLC for short, follows up with each of these congregate settings after Maine CDC has made contact with them to make sure that they are complying with Maine CDC recommendations. All of this is designed to keep other residents of congregate settings as safe as possible to minimize the risk of transmission of COVID-19 in these settings. One of the things that we know about congregate living settings is that in many cases, the individuals who live there are particularly at risk, partly because of the physical design of many of these facilities, and also because they may also be older individuals or individuals with pre-existing or chronic health conditions. This partnership between the Maine CDC and DLC really is designed to ensure that facilities have all the support they need to keep their residents safe. I'd like next to provide an update on our laboratory testing across the state. The first is the number of negative laboratory tests. As of right now, Maine CDC is aware of over 6,000 negative laboratory tests. As of last count about an hour ago, the exact number was 6,088 negative tests. That is, again, a snapshot of a very fast-moving train, a train that's actually gaining acceleration as more and more commercial laboratories are conducting more and more tests across the state. I've also talked in recent days about our procedures to increase our own testing capacity, and so I'd like to provide an update on those. The first is that our work with an outside commercial laboratory to reduce the number of tests that we have is continuing. All of those specimens have been what is called accessioned, which is to say a form has been filled out that recognizes each and every one of those specimens, and they are in the process now of being packaged and shipped. We anticipate having results as soon as possible, but we also recognize that this laboratory, this commercial laboratory itself is experiencing backlogs. For that reason, we are trying to solve this problem from both ends. The first is to continue to build out additional laboratory testing capacity within the Maine CDC's laboratory. We have ordered an extraction platform, an additional piece of equipment that will help us conduct more tests and help us move away from our existing reliance on one set of these chemicals that has been in short supply across the nation. This new platform that we're purchasing uses a different set of chemicals. And so by diversifying our portfolio, we hope to be able to keep our testing capacity up at our laboratory here in Augusta, even if chemical availability becomes a challenge for one platform. We hope to be able to rely on the availability for the other platform. Again, this is part of our strategy to diversify our testing portfolio as much as possible. Some of it involves adding new machines at Maine CDC. Some of it involves partnering with commercial laboratories to have them do the testing. And then a third piece of it is continuing to work with hospitals and other organizations in Maine that wish to bring on testing within their own facilities. It's a three-legged stool, and we at the Maine CDC are working on every strategy we can to build up the number of tests. I'd also next like to provide an update on personal protective equipment. Again, this personal protective equipment is worn by healthcare workers and direct care workers who are on the front lines every single day, providing care for individuals who are suspected of having or who might have COVID-19. About a week ago, as I've reported, Maine CDC distributed its first cache of PPE across the state. Our goal with that first distribution was to equip the least equipped across the state. Just a few days ago, we received our second cache of PPE, and that cache is now in the process of being distributed as well. We've also received notification from our colleagues in the federal government that probably by this evening, Maine CDC will be receiving a third shipment of PPE as well. What we understand is that this third shipment may be the last cache that Maine CDC receives for quite some time. We are hoping that's not true, but once again, hope is not an operational strategy in an emergency situation. And so we are pursuing other avenues to procure and produce additional PPE within the state. But based on the report that we've just received from our federal partners, Maine CDC will be receiving approximately 60,000 N95 masks, 143,000 procedure masks, 31,000 face shields, 25,000 surgical gowns, 1,500 coveralls, and approximately 184,000 gloves. We will again be adding that to our inventory and being prepared to make distributions of those pieces of protective equipment in the coming days. I'd also again like to provide a quick update on some of the vital assets across the state. In terms of ICU beds, there are a total of 176 ICU beds accounted for, of which 92 are available. There are approximately 309 ventilators, of which 253 are available. For alternate ventilators, these are ventilators that have recently been approved by FDA for use in the management of critically ill patients. These are things like breathing machines that might be in operating rooms. Maine CDC is currently aware of 87 such ventilators. We are continuing to work with hospitals to track each and every one of these vital resources so that we can plan appropriately to make adequate and appropriate requests, also so that we can load balance across the state. If we see a particular institution that is in express and dire need, this visibility into the data helps us engage in that load balancing across the state. I'd like to end on one note, which is to talk a bit more about the folks that are on the front line right now. Statewide, there's a lot going on, and we recognize that. And I'd like to take a moment to pause to thank healthcare workers and direct care workers for everything that they are currently doing right now. Across the state of Maine, everyone is trying to minimize the spread of COVID-19. And as thousands of people are staying home, healthcare workers are doing the exact opposite. They are racing to the front lines to care for those who are ill and who are in need. And it's not just direct healthcare workers. It's all types of direct care workers, whether they be in a hospital, a long-term care facility, or any of the congregate living settings that I've talked about today. But it's also the healthcare workers who we don't often acknowledge, and I'd like to do so today. These are the custodians, the cooks in the kitchen, the environmental care workers who are sanitizing the linens, the people who you might not see when you or one of your loved ones goes into a hospital. But they are the ones who are keeping the healthcare system functioning at this time of extreme stress. Each of these individuals is taking a risk. And while we are doing everything we can to minimize that risk, we must not forget that it exists. These individuals across the healthcare spectrum are doing these jobs at a time of great stress. And I'd like to acknowledge that they're not doing so in an emotional vacuum. COVID-19 has had a real, emotional, and personal impact on many of us. And I'd like to take a moment to acknowledge that these folks who are racing to the front lines every single day, while many of the rest of us are attempting to stay home, they themselves are grappling with that same personal and emotional impact, even as they are showing up to work every day to keep Maine people safe. And so on behalf of the Maine CDC and all of us working on this outbreak, we thank you. So with that, I'd like to take any questions. Michael.
You were quoted, I just want you to flesh out these PPE numbers a little bit. You were quoted in the Post this weekend as saying, we got about 5% of our allotment. Where will we be after this next distribution? And on Friday, we quoted a Maine general nurse as saying there are only enough surgical masks there for about 1 to 2 weeks. Nurses are actually bringing them home because they're scared they won't have them later, maybe when they need it. Are we at the point where this shortage is endangering people?
So Michael's question is regarding PPE and whether even with these additional allotments of PPE, we will be where we need to be. While these additional allotments of PPE from the Strategic National Stockpile may help alleviate some of the short-term needs that we know are out there, that we acknowledge that the healthcare workers who I've mentioned are contending with, it's difficult to say whether it will be enough. As you noted, Maine has received a paltry amount of PPE in comparison to what we've asked for. These additional allotments will help us, but they still remain insufficient. We are still trying to work with the federal government to determine what other allotments may be made. The federal government, as is the state of Maine, is also trying to increase production. But given that that process is unknown and the outcome is yet to be elucidated, our view within the state of Maine is that we also have to look at other strategies. One is procurement from other private vendors, and then the other is production within the state. Procurement is also a challenge because there is not a nationalized procurement system for PPE, which effectively leaves states pitting themselves against one another, which is almost the last thing you want in a situation like this. So we continue to call upon the federal government not only to release additional supplies of PPE, but also to help states manage where the situation is. One of the things that we are trying to investigate is whether additional supplies of PPE will be distributed to parts of the country that are experiencing outbreaks versus parts of the country like Maine, where there's still a viable chance at preventing a large-scale outbreak. We're working with our federal partners right now to get a better handle on that. I'm gonna turn to the phone really quickly, and then we'll go back to the room.
I just want to get
Yeah.
a number on that. I mean, you said 5% over the weekend. What's the equivalent number now?
I'm sorry.
You said Maine had gotten about 5% of the PPE it requested. What's the number now with this new?
So we've received in total from the federal government approximately 26,000 or so N95s. With this additional allotment, we'll be at approximately in total about 85,000. Very rough numbers. That's still not where we need to be. So, and we'll get you additional numbers. I would like to turn to the phone and start with Don Kerrigan. Don, go ahead.
Thank you very much, Dr. Shaw. Actually, a follow-up on that and then a question about testing. We know that some masks are being made. I believe LL Bean may be trying to do something, and some others are trying to make masks, and we've heard reports of some businesses making face shields. But are some of these other products currently able to be manufactured in Maine? And then the testing question is, how much of the increase in cases reported, can you say, is the result of reducing the backlog?
Great. So Don's first question is about the manufacturing capacity within the state. And in this respect, we have been working very, very closely with Commissioner Johnson and her team to work with private companies and other manufacturers in the state to ramp up as much as possible. From what we've heard so far, the interest level is very high. The University of Maine system is also involved in those discussions. Where we are is providing those manufacturers many of the technical specifications that the standard-setting organizations use when they are determining how PPE should be made. I think it's Don, I think we're not at the stage yet where we are able to project what the total manufacturing capacity will be. I know that those discussions are underway, and I think we'll be able to have some updates on that soon. What I will say, though, Don, is that the response from the manufacturing community has been extremely positive. We commend them for being so willing to come to the table and help out this effort. I think that Commissioner Johnson will be able to have further updates in the very near future about what the expected capacity as well as the timeline might be. Don's second question is whether this increase of cases that we've seen in recent days, to what might we attribute it? Is it a function of more disease spread? Is it a function of more testing? Or is it some combination of both? Don, let me say at the outset that this increase that we've seen is concerning to us. It is also consistent with increases that other states have seen at their similar point in the outbreak, as well as largely consistent with the increases that are now occurring in northern New England in particular. What I think that tells us, though, is that anytime we've got an outbreak, we're always trying to disaggregate or get our head around whether what we are seeing is a function of the disease spreading or just our ability to see what's going on better. And that's a phenomenon that is commonplace to any kind of outbreak, whether it's respiratory, foodborne, any type of outbreak. And in this situation, Don, it's likely a matter of both. We know that testing has increased.
Hi, everyone. I'm News Center's Lee Nelson. You've been watching Dr. Nirav Shah, the director of the Maine CDC, give his daily briefing. If you want to continue watching that will be online. We are going to do a noon broadcast here today. So ahead on News Center Maine at noon, we do have the latest numbers on COVID-19 cases. We'll bring you the highlights of the briefing. Grocery store employees are on the front lines of this fight, and both of Maine's chains have employees who've tested positive. Most of the big chains, Hannaford and Shaw's, will tell you what those chains are doing to make sure their stores are as safe as possible. Plus, a man's been charged with setting fire to an elementary school in...
I'm going to pick up another question on the line, and then we'll go back to... Don, did you have any more follow-ups?
I guess I didn't at that second, but I would ask a follow-up on the testing. Do we have enough test kits and to do those samples? And do you anticipate that at some time within the next week, for example, we will be all caught up with that backlog?
Great. So Don's question is about testing supply and the backlog. I'm really glad you raised that, Don. As of this morning, Maine CDC currently has enough supplies on hand to conduct approximately 2,000 tests. It's a very approximate number. Again, it's a lot like baking, where you've got a lot of ingredients and a lot of pieces of equipment, and determining, based on what you've got on your kitchen table, exactly how many cupcakes you can make is a bit of a difficult calculation. But roughly speaking, we have the ability to conduct approximately 2,000 tests. Where we are in terms of the backlog is that as of right now, the backlog for the patients that we know to be at the highest risk is cleared. Individuals who are either ill and in the hospitals, or who are healthcare workers and could be potentially interacting with patients, the backlog for those individuals is cleared out. So we are up to speed, and as a result of that are able to return what for many patients can be a life-saving result, or for a healthcare institution, a result that alters their care. The backlog there is up to speed. I'm going to turn next to Kara DeRose.
Hi, I just have another question related to the national stockpile. So again, Maine has only received about 5% of requested medical supplies from the national stockpile, while other states have received larger shipments more quickly. And I just wanted to know, do we know why that disparity exists? And also going back to the ventilators, do we have an estimate for the number of ventilators Maine will need in the long term?
Good. So Kara's questions are about the national stockpile receipt of supplies that we've gotten, and then also about ventilators. As far as the national stockpile, what we have received is inadequate. Governor Mills, a bit ago, a week before last, sent a letter to Vice President Pence and Secretary Azar, urging those individuals to accelerate the distribution of supplies from the national stockpile. But Maine has not received what it has asked for, and relative to other states, we have not received the same pro rata share of what we've asked for. So we have also asked, I have started to inquire of my colleagues, I should say, of what might account for those differences. What algorithm has been used by the Strategic National Stockpile to make these distribution determinations to states? Right now, as of right now, we haven't received much visibility into that. We are continuing to try to get more answers to how the officials who run the national stockpile have made those allocation decisions. But again, we're not just waiting for those answers. We're also pursuing additional strategies in order to try to shore up what we need to have right now. Now, Kara, your other question is around ventilators. We are continuing to work with experts in modeling to try to get a better handle on the number of all different types of medical assets that we might need. Now, these numbers are planning projections. They are not predictions. They are just what they are, which are projections that we must necessarily undertake as we are planning. As we have gone through that process, we have recognized that although we have already made an initial request for 300 additional ventilators from the stockpile, we believe that we might need about 50 more than what we've asked for. So we are actually officially changing our request from 300 additional ventilators from the stockpile to 400 additional ventilators from the stockpile in light of some of these planning exercises we've been undertaking. I'm going to go back to the room and then we'll go back to the phone. So Brad?
We've got 43 healthcare workers now infected. Is the lack of PPE responsible for any of that, do you know? And if not, then how are they getting it if they're wearing all the protective gear?
So Brad's question is about the healthcare workers who have been infected. Let me first start by noting that, once again, these healthcare workers are running to the front line at a time when many thousands of other Maine people are staying home. We're all doing our part to try to minimize the spread of COVID-19. By staying home, all of us are doing our part, but by running to the front lines, healthcare workers too are doing their part, and I want to begin by commending them. We are aware of at least 43 individuals who are healthcare workers. Our investigation is underway. That number may increase as well. One of the pieces of our investigation is to try to determine where any individual may have been infected from. But given that we've detected community transmission in 2 counties now, 2 very populous counties in Maine, it's difficult to know whether any healthcare worker may have acquired their infection because of interaction with the patient or from interaction with someone in their community. We always, of course, are looking for trends that might point us in one direction or the other, but as of right now, Brad, we haven't seen clear evidence that any healthcare worker has been infected in a facility. But once again, the absence of evidence is not evidence of absence. We are aware of data from China and Italy that have suggested that a high percentage of healthcare workers may have been infected with COVID-19 in those countries because of their work, their heroism in being on the job. And so that's one of the reasons why, as we move forward with the distribution of PPE in Maine from these additional cases that we've received, we're really putting a prime focus on healthcare workers and direct care workers of all types across the state. Kevin?
I want to go back to modeling. You talked a little bit about this last week, but you just brought it up again. What are the big models that you're looking at as being the most accurate?
Good.
And how do you guys go about doing this? Do you have a team that sits down and looks at all the models every day and then decides this is where we need to go?
Kevin's question is great, partly because he's captured exactly what we're doing. So Kevin's question is around modeling. And how do we go about this process, and what is that team doing? So Kevin, what we are doing, or how we think about modeling, is twofold. Our goal in doing these models is to try to get an estimate of 2 things and them up. The first is projections, planning scenarios on what the outbreak may look like in Maine under different conditions. The second is to marry those projections up with the anticipated resources that may be required under each of those scenarios. We're using 2 different types of models as we go about this work. One group of models are what are called epidemiological models. These are models that take what we know about the disease and how it spreads, some of the numbers we've talked about in this room, about how many people get infected after one person gets it, and how many people may pass. And they plug those numbers into a model, and that projects a curve. That's one type we use. And those are models that have been developed by groups primarily at Imperial College London and at Johns Hopkins. There's a second type of model that we also use. It was the most interesting and most relevant for our purposes is developed by a gentleman named Chris Murray, the University of Washington. Professor Murray used data from the actual outbreak in Wuhan and adapted that for different conditions. So that's more of what's called a best fit model. We use all of them. And because what we're doing is not looking for one model and one projection, but different models with different projections. We take those and then go to what we know about the healthcare system. We talk to doctors. Just this Saturday, I convened a call with anesthesiologists and nurse anesthetists to get their take on how many patients they might manage, how many ventilators in a certain scenario they might need. So we get from experts the number of resources that are needed under different scenarios, and then we marry those up. Our team is looking at these, and as new assumptions come in, we adjust the models. For example, one of the assumptions that had been made up until Saturday morning was that anesthesiologists would be able to manage X number of patients. In my meeting with the anesthesiologist, and by meeting, it was a virtual meeting, I asked them whether that assumption was fair. And they said no, they didn't believe that it was. And so we got new data, and then we put that back in the resource utilization piece and adjusted the model accordingly. So that's what we're doing, and that's what allows us to get a better handle on low infection scenarios, medium infection scenarios, high infection scenarios.
When you come up with your estimates, you base it on high infection scenarios, low, what's...
We're always doing a range. So there's not a number that we key off of for what we think is needed. We're always using a range. So when we talk about the number of requests we're making, even though here I talk about what the number is, it can vary, and we recognize that. So when we're doing modeling exercises, the goal is not to find the number. That's never the goal. The goal is to come up with lower bound parameters and higher bound parameters and make sure that we have accounted for all the scenarios in between. So I'm going to actually go back to the phone, and then we'll go back to the room. And I'd like to turn to Steve Missler.
Hi, Dr. Shaw. Can you hear me?
Yes, sir.
Okay. So I just want to follow up on Kevin's question on modeling. I mean, there are various ones that are out there that show, for example, I'm looking at one right now that shows that, basically Maine would hit its peak resources, that's beds, ICU beds, ventilators, et cetera, on April 25th. Is that consistent with what your modeling is showing? And I guess a follow-up after you answer that, if you don't mind.
Okay, sure thing, Steve. So Steve's question is with respect to certain models that are publicly out there that I encourage folks to go check out, to get a handle on how this stuff works and get some familiarity with it. I'd urge everyone to take a look at it. But recognize that every model is only good as the assumptions that you put into it. And those assumptions they may or may not reflect reality. Some of the models that are out there assume that nothing is done. And those are, of course, the worst case scenarios. Some assume that we adopt essentially a Wuhan-style model. The model that you're referring to, Steve, assumes some variation of physical distancing is being done. So under that scenario, it aligns with the projections that we've seen. Again, the model is just there to help us take different assumptions and then project out into the future what it might look like. The goal of modeling is not to come up with the answer. The modeling tools are only as good as the assumptions we put in, and then on the other side, how well Maine people follow those assumptions. One of the reasons that I want to stand before everyone today is to ask everyone to go forward with that physical distancing, because the more aggressively we can impose those, the more closely we can come in with those lower projections. The less physical distancing that's done now, the more physical distancing that's going to have to be done in the future. And so that's kind of the essence of modeling. It's not just a singular thing like balancing your checkbook, where you do the numbers and you get to one single answer, and it's either right or wrong. It's using different scenarios, and with the right assumptions and the right scenarios, any model could be accurate. Our goal is to use those as a way to try to figure out where we should be urging people and what steps we should be making. Steve, I know you've got a follow-up, but let me know if that's not responsive to your question.
No, I think it is, but I think with that in mind, I guess I have just a 30,000-foot question here, especially given what you discussed with the PPE situation, and this apparent warning from the feds that we may not get what we've asked for. And I guess if the federal government is not going to be a reliable supplier of this equipment, which we need, does that mean that the state should be taking additional, more stringent steps to flatten the curve, to do, as you just said, to be as aggressive as possible on social distancing, especially if, our healthcare workers aren't going to get the protective equipment that they may need, at least from the stockpile or the federal government? I know you're pursuing other avenues here, but unless those things come to fruition very quickly, it seems as though you may be looking at some additional steps that the state might need to take.
Yep. So Steve's question is, in light of these different projections, whether additional policy recommendations ought to be introduced from a social distancing perspective. And Steve, it's a great question. We discussed this. And it is the case that if we are able to impose and really abide the social distancing, the physical distancing that we and others have recommended, we may come in at the lower bound of these models. And in some of them, the resources that we have may be adequate. If those measures are not as well followed, we may have more challenges. So the question there then, Steve, is where else we might go on top of what's already been done. And what we've seen from data, particularly going back to the 1918 situation, is that it really is about where individuals congregate. And in that respect, I think the measures that Governor Mills are right, which is to say recommending or requiring the closure of non-essential businesses and recommending the imposition of physical distance for those remaining essential businesses that are open, because that is where individuals may congregate. I think that's the right balance because it really is about those areas of congregation. Now, I should say all options, we're always evaluating options. That's what we do. We're an open organization. That's how we think about every single problem. But I think where we are right now versus where we might go is pretty much right. And so I'm happy to talk more about that. But that's our thinking on this right now. Steve, go ahead, Steve. Yep, and then we'll go back to the
question. You can go back to the room, and I'll leave you alone.
Yeah, that's all right.
I had a quick question about this new test by Abbott,
Good.
Which can deliver results in as few as 5 minutes, negative results in about 13. Do you know if that testing capacity will be used in Maine, and when that might be deployed, if
Good.
it is?
What I can tell you is that I have been personally following, as well as our team, have been personally following those developments. We recognize the various connections that manufacturer has to our state, and what I will tell you is that we are very interested in it. So we're very interested in it. So I'm going to go back to the room and go to Dustin.
To follow up on that, the president characterized it as a game changer yesterday. Are you prepared to go that far? What else do you know?
Yeah. So it's a big step forward. There's no question about that. Here's why. Here's the data that I'm looking at, or looking to look for. The test itself requires any organization who might use it to already have the platform in place. And so if an organization does not have this platform, it's called the ID Now platform. If they don't already have that, well, what's the supply chain of that platform? So that's a question that that's got to be answered. And then, as we've talked about, all tests on some level require chemicals. And so what is the available supply chain of the chemicals that this test requires? It uses a slightly different testing modality than, say, what our laboratory here in Augusta uses. And so we've always got to ask hard questions about what the expected supply chain is. We're very interested in this test because of its ability to return a result very quickly. That's a benefit, and hopefully in the coming days, I'm very much looking forward to discussing with everybody my thinking on this. But I want to try to make sure I get answers to some of these questions before I get ahead of myself. We're very interested in this platform because of its speed as well as its accuracy. But we've got, before we double down on any one testing strategy, we've got to make sure that this supply chain problem that we've talked so much about is one that is appropriate. I also just want to make a note as a footnote for clarity. This strategy is what's called a point of care test. It is intended for use at maybe not the bedside, but at the clinic side or at the emergency department side. It's not a strategy that would be utilized at our laboratory in Augusta, which is running hundreds of tests per day. It would be a strategy that we would use in concert with the healthcare provider community as opposed to at our laboratory. That's a good thing. This is a situation where multiple bets are on the table. We're taking a multi-layered approach. That's what we want. But for clarity, I just wanted to explain where that test fits into our architecture. I hope in the coming days I will be able to talk more about how this test fits in with another area that we've talked a lot about. Once I've got more answers, then I will be happy to. But again, I want to give it to everyone straight. I don't want to get ahead of my skis. We're going to go, yes, go ahead.
Understanding that there's limitations on modeling, is Maine currently exceeding its hospital capacity under the medium, low, or high scenarios, or all three?
Based on where we are right now in Maine, there is existing capacity. Just to, in terms of the number, one of the numbers, the two numbers that we are, among others, really interested in are the total versus available number of intensive care unit beds and the total versus available number of ventilators. As of right now, there are about 176 total intensive care unit beds. There are about 92 that are available. And then with respect to ventilators, there are over 300 available. If you add in these alternative ones, close to 400 available, or in total, and about 250 are available. So there is capacity in the system. However, none of us should take solace in that. What we know from other states, especially states in the Northeast, is that more cases will be occurring. And the number of those cases, as well as the geographic spread of those cases, will be significant. So even though these numbers right now are not at maximum capacity, the scenarios that we are planning for are ones in which we have met or exceeded the maximum capacity. So no question about that. I'm going to go back to the phone and go to Megan Torgeson.
Hi, Dr. Shaw. Thanks for taking my question. I am asking, well, we see what's happening in Rhode Island right now with people coming into the state allegedly from out of state. We've heard a lot of anecdotal stories about that happening here in Maine, though it's hard to necessarily prove. Do we have some sort of strategy to address this problem, or are we talking about this problem? How is this something that's on the radar?
Good. So Megan's question is with respect to individuals who may be coming to Maine from out of state. And I want to just start by noting an update that occurred Saturday night, which is the U.S. CDC issued a travel advisory for any residents of New York State, Connecticut, and New Jersey to advise them against any type of travel for the time being. And the travel advisory recommended that the governors of those states impose those travel advisory restrictions as those governors see fit. So by implication, those individuals, other than those deemed essential from those three states, should not be traveling according to the U.S. CDC. That being said, what we also know in Maine is that coronavirus is here. It has been here for quite some time. It is widely circulating in at least two of our most populous counties, and we anticipate it circulating elsewhere. So as with everything, we are always thinking and looking at options, but we have to consider what the public health benefit, the public health approach to any further actions might be on top of the architecture that's already in place, on top of an advisory by the U.S. CDC for residents of those certain states not to travel, a recommendation by the White House from Dr. Debbie Birx that individuals who do travel to look out for symptoms. So we're always looking at different options, but we always have to consider what those options may mean on top of what's already in place. I'm going to turn next to Amy Brown on the phone, and then we'll go back to the room. Amy, go ahead.
Thanks, Dr. Shaw.
I wanted to follow up on something that was reported on Friday's briefing. I think you were explaining that the way the number of cases are listed is based on the place of residence of the person rather than where they are currently located. And so I just wanted to make sure I'm understanding this correctly. If someone from Maine is tested outside of the state, is that still counted in Maine's numbers under the county in which they reside? And conversely, if somebody from out of state tests positive here in Maine, are their numbers included under our numbers or on their state's roster?
Good. So Amy's question is how state health departments across the country work together to report cases and avoid double counting. And the way that state health departments approach any disease, whether it's tuberculosis or COVID-19 or measles or name your infectious disease, is that the disease is counted as where the person is a full-time permanent resident. So if you happen to be visiting California for the weekend and you happen to get diagnosed with mumps and you're on your way back to Maine, that case is counted in Maine because you're a Maine resident. In the same way with COVID-19, the way that the Maine CDC and every other health department in the state handles these cases is that we look to see where someone is a permanent resident. So, Amy, to your question, yes, if someone from Maine were traveling to South Carolina and got diagnosed in South Carolina and was intending to stay in South Carolina for a couple of weeks, that case would be counted in Maine. Similarly, an individual who is visiting from another state and happens to get diagnosed in Maine, they may get, we do an interstate transfer, and that case is managed by their state's health department. We do this to avoid double counting, but it's important to recognize that with a disease that is already here, that is already widely circulating, with a disease that we anticipate additional community-level transmission, whether someone is an out-of-state resident or an in-state resident should not change the precautionary measures that I really urge everyone to start taking. Now is the time to make sure you and your family are fully prepared, whether that's for medication, for social distancing, to be prepared for the possibility that COVID-19 is already in your county. Going to go back to the room. Yep.
You mentioned that there's an investigation into Penobscot County community transmission there. Mm-hmm. Now that Kennebec has hit 10, are you guys looking into that one as well?
Same thing.
Okay.
So the question is, again, with this investigation into community transmission, we are looking at each and every one of those cases, 12 in Penobscot, I believe 10 in Kennebec, but that might be changing once we define where the counties are from. But over 10 cases in both counties, if we determine that at least 25% of those cases has no connection with another known case or travel, that's the threshold at which we will determine that community transmission is occurring. And that investigation's underway. Going to go over to the side of the room. Brad.
We had a big spike in cases over the weekend. Is the increase of that increase, is that because we're getting caught up on the testing, and where are we at with the backlog?
Okay, so Brad's question is whether another potential reason for the increase of cases that we've seen could be that we've reduced some of the backlog. As I reported about a week ago, maybe over a week ago, the number of cases that were backlogged was up to 1,300 cases. We've actually just internally within the Maine CDC laboratory reduced that by about 500. So, Brad, it is possible that some of the additional cases we've seen are because our laboratory has received reagents. That's really the key to all of this. Our lab staff worked all weekend. They have been working every single weekend. As much as they can, 7 days a week, our lab staff has been putting in long hours to try to attack this problem from both ends. So it is possible that one potential reason for the increase in cases is that there's more testing going on. That's always a possibility in any outbreak. But the other possibility that we have to be equally concerned about is that there's more spread going on. In epidemiology, this is the $64,000 question in any outbreak. Is there more testing going on, or is the disease spreading? And that's what we've got to always think about. Back over to Kevin and then over to Michael.
kind of a follow-up on that, more than 200 of the cases are from Cumberland and York County, and obviously there's community transmission. From what you've seen, and I think that you live in that part of the state, from what you've seen, how have people been complying with social distancing? Are you still seeing things that are concerning you? And I guess any general comments on that?
Yeah, Kevin's question is, in my neck of the woods, based on what I've seen, is social distancing, physical distancing, as I like to think about it, has that been happening? Are people complying? And the answer is yes. And I'm only speaking anecdotally here, just on my own personal observations, not referring to any data. But the answer that I've seen, or what I've witnessed, what my family and I have witnessed, is yes. So much so that just on a recent morning, when I was walking the dog, there was another person with their dog coming, and we kind of sort of nodded at each other from 100 yards away, and we both crossed the street. We crossed the street just out of extreme safety. When I've driven down the main street in our town, it's there's activity, but it's what it should be. Friday night, my family and I got takeout from a restaurant in order to support a local restaurant that we really like. And the restaurant that we visited had a really great system in place where there was no face-to-face interaction to pick up your takeout. You prepaid over the phone. You walked in. They had a table at the very beginning, at the very top entrance, with everyone's names on it for their orders. You grabbed your orders and you walked right out. So based on just my anecdotal observations, purely anecdotal, one guy's observations is that folks are heeding this call. And that's disheartening, because we're in a situation where the actions that any of us take today could impact the health of everyone in the community tomorrow. And so I commend everyone for going down that route. Michael.
Yeah, I just wanted to put a finer point on the out-of-state visitors question. I mean, when it comes to spreading this virus, what's the relative difference in risk between an asymptomatic person like you or I here already and asymptomatic people from harder hit areas like New York City or Boston? I mean, as long as they're all following the same protocol, it doesn't seem like there's much residual risk there. But
so Michael's question is, for individuals who may be coming to another part of the country from harder hit areas of the country, is there a higher risk? And Michael, according to the U.S. CDC, pursuant to their travel advisory, I can only infer that there might be, in fact, a slightly higher risk. I don't know that. I haven't seen the numbers myself, but by implication, if there weren't, it stands to reason that U.S. CDC would probably not have issued that do not travel order for people coming from New York, New Jersey, and Connecticut. I don't know how much higher that risk might be. Even if it is higher, that advisory may have also been taken out of an abundance of caution. So I don't want to, I'm going to give it to you straight. Perhaps that risk is higher even for an asymptomatic person, but that's actually not my hunch. My hunch is a little bit different. My hunch is that what they are worried about is individuals who are symptomatic, who may be moving elsewhere. Based on what we know right now, the risk of anyone who is asymptomatic is not different from you or I. But it's difficult to say. There's new data that are coming out. I can share some of the new data that were just presented on Friday, maybe not this minute, but there's new data that have come out about this differential risk. And so there's more to come on that.
Have you seen heard any anecdotal cases of symptomatic people moving into Maine? I mean, coming into Maine.
I haven't heard. I've heard, but that's just literally hearsay.
Nothing reliable.
Yeah, nothing reliable. Yep.
Are you aware of any staff or people in custody with the Departments of Corrections being tested for COVID at this time, and have any of those come back positive?
We had a briefing this morning with our colleagues from Correction. There have been a few individuals in the correctional system who have been tested, which would be expected. It is flu season. Symptoms are not uncommon. But as of this morning, no client of the Department of Corrections has tested positive. So, Brad?
Do you have any information as far as the people who passed away, where they may have, where they likely contracted the virus?
That investigation is underway right now. We don't have anything to report at this time. for privacy reasons, if there's a public health risk that we uncover, we would report that. But if it was, say, community transmission or something of that nature, for privacy reasons, we wouldn't go into it. You got a follow-up? Yep.
Do you have any information about the Army Corps of Engineers possibly setting up a field hospital, where that would be? Probably Cumberland County, I'm guessing.
We haven't, no locations have been decided upon. What I can tell you is that the Army Corps, in concert with their colleagues at FEMA and MEMA here, have been working with colleagues across the state, including at the Department of Health and Human Services at the most senior levels, to try to identify potential locations. No decisions have been made. As we are doing, we're trying to balance availability with suitability with where the disease risk might be the highest, and trying to merge those three up.
Field hospital?
Can't speculate on that. We're planning. Our job is to worry in advance. So we're planning for all of those possibilities, but we're not speculating, and there's certainly not a threshold for the number of cases at which we would take action. In the same way, there's not a threshold where I want people to take action once it hits their county. We're not waiting in the same way here. Last question, please.
Can you talk about any modeling you've done about the true number of positive cases here in Maine compared to the number of positive cases that we know?
Yep. So in any outbreak scenarios, as we've talked about, there's always a part of the iceberg that we don't see. And with COVID-19, there aren't really great models in place yet about what percentage of that iceberg nationwide, worldwide, is seen versus unseen. So when we do our modeling, we use different assumptions. We build one model with a scenario that says we are detecting half of the cases. We use another model that says we're only detecting 10%. And we're not sure which one it is. I'm not aware of any definitive peer-reviewed, CDC-approved, US CDC-approved research that has said for this outbreak, this is the proportion of seen versus unseen. We do have those models for things like tuberculosis, for measles, but because of the newness of COVID-19, those models really haven't been developed. So that's why when we do our modeling, we use a range of assumptions. And again, that's how modeling is done. It's not intended to find the answer. It's intended to provide us a broad range of answers so that we can think about how our planning should go. Again, I want to end on one last note, which is, again, to thank healthcare providers, direct care providers, and everyone in the healthcare system, custodians, cooks, people who are washing the linens, medical records folks, everybody in the healthcare system right now, who, while the rest of us are heeding the advice of public health officials to stay home, those healthcare workers are doing the exact opposite and racing to the front lines. We would not be able to care for ill individuals across Maine who need help right now were it not for you. And so on behalf of the Maine CDC and everybody working on COVID-19, I thank you. With that, thank you all very much. We'll see everyone soon.